So good evening, everyone. Let me start off the session by explaining the concept of critical limb ischemia and how we go about decision making in CLI. So we've all heard of peripheral arterial disease or peripheral vascular disease, but the real question is, are all PVD critical? So the simple answer is no. If you look at the natural history chart, you see that most of these patients are actually asymptomatic, a vast majority. Another good number of patients are having claudication symptoms. And if you follow up these patients by the natural history, you see that many of them actually remain stable. Very few of them become critically ischemic. But on the other hand, there's only a small subset of patients who have critical limb ischemia. And if you follow these patients for even a year, you see that they have very bad limb or life outcomes. So it is this group of patients that we are very concerned about and we try to aggressively treat. So what exactly is critical limb ischemia? I'll try to show through few examples. So let's see this particular gentleman. So he came with an infected third toe. He went to a local doctor. It was badly infected, so it had to be amputated. But in spite of multiple dressings, you can see that the wound had just failed to heal. There's another lady who had an infection in her heel. This was also some sort of debridement was tried, but you can see that the wound has only progressed and it has no signs of healing. This gentleman actually came with a gangrene of his second toe. Somebody amputated the toe, but the wound has only become worse. And you can see that the third toe and the first toe has also moved on to be gangrenous. This gentleman has been having severe rest pain for the last 2 to 3 weeks, and he has barely been able to sleep. You can see he keeps his limb dangling from the bed, and also some sort of an edema has come because of that. This old frail gentleman actually didn't have any symptoms. One day his son came to visit him, and his son is the person who found this particular lesion in his foot, and you can see that it doesn't look healthy at all. So in short, critical limb ischemia is an entity if any of these are present. So ischemic rest pain or a non-healing ulcer or gangrene. So how do we go about clinically assessing it? So like we showed before, the foot itself all very often tells. You can see poorly healing ulcer, or you have an edge necrosis, you have gangrenous changes. And um, uh, I can't stress more on the need to palpate the peripheral pulses. So all the peripheral pulses of the lower limb has to be systemically examined, femoral, popliteal, posterior tibial, dorsalis pedis, and it only not only does it help in helping to make the diagnosis of peripheral artery disease, you can also probably locate where the disease is based on which pulses are present and absent. If you have the handheld Doppler, it further helps in your clinical assessment. You can measure the ankle brachial pressure index, although it may not always be reliable. If the values are definitely less than 0.4, there is surely severe ischemia. If you have the facilities, toe brachial index, TCPO2 are also add-ons. Now, I would like to bring in this important guidelines that we now tend to follow for critical limb ischemia. This is the global vascular guidelines that was recently published last year. It is a comprehensive guidelines made by various vascular societies across the world. And we are proud to say that we also have the Vascular Society of India represented by our senior member, Dr. Suresh. So this guidelines has actually brought in a new term, so that is chronic limb-threatening ischemia. So this is the term that is now more accepted. CLTI, so it basically is PAD, where there is also ischemic rest pain or a diabetic foot ulcer or non-healing ulcers that are not healing for more than 2 weeks, or gangrene involving any part of the lower limb or the foot. Now, we have all heard of many scoring systems for foot ulcers like Wagner, Pedis, Rutherford, etc. But there was still a dearth of a good staging system where many criteria could be brought in together. So the latest, I think the most acceptable one is the wound ischemia foot infection, or the Wi-Fi scoring system. So this is sort of akin to the TNM scoring system that we use for staging cancer. So this is a way of staging the leg. So each of these, wound, ischemia, and foot infection, is graded from 0 to 3. And using a combination of that, we can stage the leg from stage 1 to stage 4. So it may seem a little cumbersome, but we have apps available for this. And you just have to put in the values and you can get the stage of the leg. So this is elaborate Wi-Fi staging stage classification. You can see how each wound, foot infection, and ischemia is graded. So with these combinations, you can stage the leg. So if the higher the stage, that is stage 4, it is the more risk of limb loss, or amputation and the more benefit of revascularization. So in short, when we suspect a patient with critical limb ischemia or chronic limb-threatening ischemia, you do clinical assessment, Doppler or ABI measurements, and if there are evidence of vascular insufficiency, you stage the limb by the Wi-Fi staging system, and then you, if the patient is a candidate for revascularization, go for appropriate vascular imaging. Various imaging modalities available, the simple arterial duplex to the more elaborate angiographic studies, CT, MR, or catheter-based angiography. I'm not going to elaborate more because I think the subsequent speakers will do that. Now, finally, how do we decide when to treat and how to treat? So the Global Vascular Guidelines has brought in a very nice acronym known as PLAN. So our intention is to basically give a good treatment, a durable treatment, and a useful treatment to the patient without adversely affecting the risk to the patient. So we look at the patient risk, that is the P, the limb severity, the L, that is the Wi-Fi score, and finally the anatomical complexity that the angiography shows. So based on the combination of these three, we decide whether we can treat the patient and whether in what modality of treatment can we offer. Now, I would like to stress here that most of the CLTI or diabetic foot ulcers are actually amenable to revascularization, and we should try to offer it for almost all patients. Now, we all know the anatomy of the foot circulation, right from the aortic bifurcation, the common iliac, external iliac, the femoral arteries, popliteal artery, and finally the tibial arteries, the three of them, which finally give the pedal circulation and formation of the pedal arch. So what our intention to do while we treat critical limb ischemia is to get an inline pulsatile blood flow to the foot by at least one artery. So that system is known as the target artery pathway. So if you look at this particular example, you can see that the patient has an occlusion in his SFA here. Then he has the best artery below the knee is anterior tibial, and that has stenosis. So our target artery pathway is the SFA and the ATA to get an inline flow to the foot. Again, there are various anatomical staging systems. I'm not going to elaborate, but the task and the glass, and the more higher the stage, the more complex the lesion. One important thing I want to stress is the timing for revascularization. So if a patient has dry necrotic wounds or dry gangrene, it's best not to put a knife on this patient before doing the revascularization. And if the patient has a wet gangrene, of course, it's worth doing the source control of the sepsis and then doing the revascularization, and finally the definitive debridement. Again, there's evidence to say that the earlier you revascularize the patient, the smaller the wound, the best the results. So ultimately, I want to stress that management of CLTI diabetic foot ulcers is a multimodality approach. We have not only the vascular surgeon, but various other general surgeon, podiatrists, plastic surgeons, endocrinologists and physicians, and various other allied specialties like physiotherapists, dietitians involved in the care. So we start off with optimal medical management, risk factor control, commence antiplatelet statins, aggressive wound management, and in the midst of all this, we provide the most suitable revascularization technique for the patient. So thank you for your listening.